Okay, so what I'm going to cover today is we're going to work our way up to talking about how unilateral and bilateral damage to different cranial nerves negatively impacts chewing and swallowing. And we're going to talk about how unilateral and bilateral damage to the upper motor neurons negatively impacts chewing and swallowing. When I say chewing and swallowing, specifically, I'm referring to what happens during the 4 stages of a normal swallow. But before we get there, let's zoom way out and start a quick review. What is this? Brain and spinal cord, central nervous system, right? Spinal cord is part of the central nervous system. Plans of volitional motor movement are generated in the frontal lobes of the brain, the left and the right frontal lobes. Looking at the 4 stages of a normal swallow, it's the oral transit and oral prep. It's the oral prep and oral transit stage that are under your volitional control. So these motor signals are largely originating at the frontal lobes. The pharyngeal swallow originates in the brainstem, but we're going to worry about that in a little while. Okay, so this is a review ultimately of upper and lower motor neurons and cranial nerves. So let's generate a motor plan in our left cerebral hemisphere, our left frontal lobe. There it is. All right. And let's change from a sagittal view to a coronal view of the brain. All right. So now we have our left and right cerebral hemisphere, the brainstem, and the spinal cord. And our motor plan that we've generated in our left cerebral hemisphere has to get efferently, it has to move efferently down through the CNS. How does it do that? And by the way, here's a review of midbrain, pons, and medulla. These are the 3 sections of your brainstem. So how is this motor plan going to move efferently through the left cerebral hemisphere, through the brainstem, and possibly through the spinal cord? The upper motor neurons. That's how. Those are the wires within the efferent wires within the central nervous system. So let's move our motor plan efferently. From there to there to there. Okay. So now, how does our motor plan get from the upper motor neurons in the central nervous system out to the muscles in the body? The upper motor neuron will be transmitted through the peripheral nervous system. And not just any part of the PNS, because it's a motor plan, it's going to be transmitted through the efferent portion of the peripheral nervous system. And those motor components of the PNS are the lower motor neurons. So here we have our motor plan that has just been sent down through the upper motor neuron, and now it's going to be sent out along a lower motor neuron so that it can get to a muscle and tell that muscle what to do. So here's our motor plan being sent out, and then it's going to get to a muscle, and then bam, the muscle is going to move according to the motor plan that was generated in the contralateral frontal lobe, sent down the upper motor neurons, and then out the lower motor neurons. Also, remember that upper motor neurons are bilateral, meaning you have a right and a left upper motor neuron. Here we have the upper motor neurons descending and coursing through the cerebral hemispheres, through the brainstem, and down through the spinal cord, because the spinal cord is central nervous system. Also remember from motor speech that the upper motor neurons decussate at the medulla. That means the right upper motor neurons cross from the right side of the central nervous system over to the left, and the left cross from the left side of the central nervous system over to the right. All right, this is not going to directly come into play, but some of you guys may be generating the questions in your mind, so I'm going to clear up any confusion. You may remember that most of the cranial nerves plug in to the brainstem at the midbrain and the pons, above the level of decussation. And yet, the cranial nerves are contralaterally innervated by the upper motor neurons as well. Each cranial nerve has its own little upper motor neuron branch that decussates over to synapse with it. Okay. So the cranial nerves are plugged in to the contralateral upper motor neurons. The only reason I'm saying this is because some of you guys might think to yourself, well, the cranial nerves are plugged into the brainstem above the point of decussation, primary decussation, and that's true, but what we probably have avoided to some degree is acknowledging that the cranial nerves each have their little on upper motor neuron decussations. Okay. Also keep in mind that the cranial nerves are bilateral, meaning that you have right set of cranial nerves and a left set of cranial nerves. So when I talk about the cranial nerves each having their own little upper motor neuron branches that decussate over from the opposite side of the body, this is really only important for you to realize what you already know to some degree, which is that most of the body is contralaterally innervated, meaning that everything on the right side of your body is going to receive motor plans from the left cerebral hemisphere, and everything on the I got my hands mixed up. Everything on the right side of your body receives motor plans from the left cerebral hemisphere, and all of the left side of the body receives motor plans, volitional motor plans, from the right cerebral hemisphere. The only time we talk about that's not the case is the upper right and left quadrants of the face, which you may remember from motor speech, are bilaterally innervated, meaning that your upper right part of your face is contralaterally innervated, meaning it receives, these nerves receive upper motor neuron plugins from the contralateral upper motor neuron, but also the ipsilateral upper motor neuron. But that's probably not going to come into play here. I'm just sort of setting the table and clearing up any confusion that some of you may have if you're thinking past what we're actually covering. So between the upper motor neurons decussating, most of the upper motor neurons decussating at the medulla, and the cranial nerves above the medulla, each having their own upper motor neuron decussation from the opposite side, that accounts for how the body, in large part, is contralaterally innervated. Another blast from the past is the word cranial nerve nuclei. This is the point where the cranial nerves synapse with the upper motor neurons. So when the brainstem is damaged, if you imagine that there's 10 cranial nerve nuclei spread around in this brainstem, then you could see that it'd be hard to damage the brainstem without damaging the cranial nerve nuclei. And if the cranial nerve nuclei is the point of connection between the upper and lower motor neurons, then you're going to have lower motor neuron damage when you damage the cranial nerve nuclei, because that's where the lower motor neurons connect. So you're going to have some outcomes to that problem that would be associated with lower motor neuron lesion, meaning you're going to have flaccidity. Okay, now let's start talking about some cranial nerves. And here's this guy. And we're going to start with the hypoglossal and the facial, because that's very illustrative. But let's remind you guys that lower motor neuron lesions result in flaccidity. Flaccidity is hypotone, weakness, hyporeflexia. Hypotone meaning muscles too loose, hyporeflexia meaning a lack of appropriate reflexes, and weakness meaning an inability of that muscle to carry out movement as the person intends. Weakness or paralysis is fine if you want to use the word paralysis. Whereas upper motor neurons create spasticity. What is spasticity? Remember that it's hypertonia, so too much muscle tone, muscles are too tight. Hyperreflexia. Reflexes are hyperactive, they're too strong, and there's abnormal reflexes present, like infantile reflexes, baby reflexes. Also, hyperreflexia is going to create a hyperactive stretch reflex that's going to make it difficult for the person to stretch their muscles. So in an upper motor neuron lesion, the volitional motor plans are saying extend the arm, while the reflexive, hyperreflexive pathological stretch reflex is simultaneously sending a signal out saying resist that stretching, that extension of the arm. So that resistance to movement of the body is what is manifested in hyperreflexia to create spasticity. So what is spasticity? Hypertonia, hyperreflexia, creating resistance to movement, and weakness, an inability of the person to move their body as they need, as they want to. All right. So now we've talked about what happens when you have an upper and lower motor neuron lesion, and the cranial nerves are peripheral nervous system. So the lower motor neuron components, the cranial nerves, so the efferent components of the cranial nerves are lower motor neurons. So when you damage the cranial nerves, you're damaging lower motor neurons, you're creating flaccidity. So let's damage this guy's, what is that, his left So let's cut his left hypoglossal. Hypoglossal innervates what? The tongue. Efferently innervates the tongue, so motor to the tongue. So if you damage the left hypoglossal, and this is innervating the tongue, then what's going to be the outcome? Well, it's going to be flaccidity, because you're damaging a lower motor neuron. The flaccidity is going to be on the same side of the body as the lesion. So in this case, we're talking about the left side of the tongue is going to be flaccid because you've damaged the left hypoglossal. Because it's the left hypoglossal that innervates the left side of the tongue. So the outcome to a lower motor neuron lesion is always flaccidity, and that flaccidity is always on the side of the body ipsilateral to the lesion. So here we have our guy now with his flaccid tongue. Now in motor speech, this would be where we would say if that flaccidity affects speech, then that would be flaccid dysarthria. But now we're going to say if that flaccidity, that unilateral left lingual flaccidity affects chewing or swallowing, then that will be a dysphagia. And remember that the tongue is going to deviate. Well, when you're looking at the tongue, lower motor neuron issues are going to appear with the tongue because the tongue will be atrophied, so it will be shriveled up. So you'll see wrinkles on the side of the tongue. That indicates lower motor neuron issues. And also when you look at the tongue, there will be fasciculations. So remember that with a lower motor neuron lesion, upon extension, the tongue will deviate towards the weakened side. So looking at these guys, and this is the kind of thing you would see during your oral motor eval. Looking at this patient, the tongue is deviating to the left, so there's a left lingual weakness. Same with this child, tongue is deviating to the left, so there's a left lingual weakness. And this person, the tongue is deviating to the right. The strong right side of the tongue is pushing, the strong left side of the tongue is pushing the weakened side over to the right, indicating a right lingual weakness. This guy, left lingual weakness, left and right. So how does unilateral damage to the hypoglossal negatively affect the 4 stages of a normal swallow? Now let's think about it. Let me pull up the right slides. All right. So if we're looking at the oral prep, what happens during the oral prep? Food is placed in the mouth. You have the mandible chewing. You have the tongue moving the bolus, moving the food between the dental arches as the mouth is generating saliva. The cheeks are tensing, keeping the bolus in the center of the mouth, keeping the bolus from falling into the buccal cavities. The back of the tongue is elevated to prevent any premature posterior spillage of the bolus. So if you have a weakened unilateral weakness of the tongue, then the things involving the tongue are not going to be working as well. So bolus manipulation is going to be more difficult. So problems with bolus manipulation, that is an oral dysphagia. The back of the tongue is not elevated appropriately because of unilateral weakness, then there's a greater possibility that there's going to be some premature spillage into the pharyngeal cavity. Premature spillage is going to be problematic, potentially cause aspiration and penetration. So posterior spillage or premature spillage is the same thing. If this happens, this would be an oral phase dysphagia. During the oral transit stage, mastication stops and the tongue sort of grooves itself and moves the bolus posteriorly towards the pharynx. If one side of the tongue is weakened and flaccid, then it's not going to be able to potentially transmit the bolus posteriorly. So there may be a deficit in AP transit, antero-posterior movement of the bolus, that we refer to as AP transit. So problems with AP transit, it's an oral stage dysphagia. All right, now let's think about the tongue during the pharyngeal stage. So normally the bolus rolls off after the oral transit stage. The bolus moves off the back of the tongue and the pharyngeal swallow is cued as the bolus moves into the pharynx. And when that happens, the velum is going to rise and seal off the nasal cavity while the true and the false vocal folds are coming together to seal off the airway, while the larynx is being elevated and the epiglottis is being brought down to seal off the airway. And then the walls of the pharynx, the posterior and lateral walls of the pharynx, are going to constrict to narrow the path of the bolus through the pharynx, directing that bolus hopefully safely over the airway. And as that is happening, the back of the tongue is going to retract. And it's going to push the bolus down. It's going to help facilitate the bolus by pushing the bolus down through the pharynx towards the esophagus. So if one side of the tongue is weak, then you might have poor lingual retraction, which could cause difficulty moving bolus through the pharynx during the pharyngeal stage of the swallow, creating stasis or residue, pharyngeal stasis or residue after the pharyngeal swallow. And that's problematic because you don't want to have residue sitting in the pharynx. That hasn't been cleared safely. Because there's the potential of it falling into the airway. All right, now what if you damaged both right and left hypoglossal? Then the tongue, both sides of the tongue are flaccid and weak. At least when you damaged only one side of the hypoglossal, you still had half of the tongue would be working. So you have some lingual function. If you damage both sides of the hypoglossal, you're going to have much more reduced function of the tongue, meaning that all those things we just talked about that were affected by unilateral damage to the hypoglossal are going to be rendered much worse. You're going to have much more severe oral dysphasias as a result of bilateral damage to the hypoglossal. So bolus manipulation is going to be much more severely impacted by bilateral damage to the hypoglossal, bilateral flaccidity of the tongue. Posterior spillage is going to be much more likely if both sides of the tongue are not able to bunch up in the back and hold the bolus anteriorly. Bolus transmission through the pharynx during the pharyngeal stage is going to be much more likely to be negatively impacted, resulting in much more pharyngeal stasis. Okay, now what about cutting the facial? So here's our left facial nerve that we've sliced here. So you'll remember that damaging the left facial is going to create a flaccid weakness on the entire left side of the face, top and bottom. But we don't use the top of our face during the 4 stages of a normal swallow, only the lips. So if we have rendered the left side of the lips flaccid and weak, how is that going to affect the 4 stages of a normal swallow? Well, during oral prep, lips have to be sealed. Otherwise, you're chewing and you're going to be spilling parts of the bolus out of your mouth. If you're trying to drink, you're going to be spilling liquid out the front of your mouth. This would be called anterior spillage. So anterior spillage is basically anything spilling out of your mouth. Posterior spillage is anything spilling back into the pharynx. So the oral dysphagia created by unilateral flaccidity of the lips created by damage to the left facial nerve is going to be probably a mild anterior spillage. Now, we don't usually eat with our mouth open, not just because it's rude, but because it's hard to do, right? If you try swallowing, like doing a pharyngeal swallow with your mouth open, it's sort of it's difficult because there are pressures involved, and having your lips sealed allows you to have the appropriate movement of pressures in the pharynx so that you can move the bolus through the pharynx safely. That being said, the primary issue would be with the lips, and this would primarily affect oral prep in that mild anterior spillage. If you damaged both the left and right facial nerves, then both sides of the lips are going to be flaccid. Anterior spillage is going to be much more severe. But oral transit is probably not going to be affected. And the pharyngeal stage might be a little bit difficult, but people are probably going to be able to manage as long as there aren't any other issues. All right. So there's the role of the hypoglossal in the 4 stages of a normal swallow, the dysphasias that are created from damage, unilateral and bilateral damage to the hypoglossal, the role of the facial nerve in chewing and swallowing, which is movement of the lips, and the dysphagia created by unilateral and bilateral damage to the facial nerve. And remember that when you're doing your oral motor eval, that when you have damage to unilateral damage of the facial nerve, you're going to have weakness, ipsilateral weakness on the affected top and bottom parts of the face. So here in this image, you recognize the unilateral right facial weakness. The mouth, upon retraction, the mouth is deviating towards the strong side. So whereas the tongue deviates towards the weakened side upon protrusion, the mouth, when you smile, it pulls to the strong side. So the mouth deviating to the left indicates that there's a right weakness of the lips. And also notice that there's not any wrinkles on this side of his forehead, indicating there's not really any there's not any muscles contracting over here, so that would indicate hypotone. And there are fewer wrinkles around the eye. And this crease, this facial crease, is much less than the opposite side, all indicating right facial nerve damage. Okay, what does the trigeminal do? You guys may remember that the trigeminal innervates the muscles of mastication, and it does sensation from the face. So unilateral damage to the trigeminal is going to create a unilateral flaccid weakness on that affected side of the mandible. So if you damage the right trigeminal, then the right muscles of mastication are going to be flaccid and weak. All right, so thinking about the 4 stages of a normal swallow, oral prep. How are you using your mandible during your oral prep? You're using the mandible to chew. So your ability to chew is going to be reduced with unilateral damage to the trigeminal. You're probably going to be chewing on your strong side. Bilateral damage to the trigeminal, creating bilateral flaccidity of the muscle of mastication, is going to be much more severe than unilateral. With unilateral damage to the trigeminal, I could still chew on my strong side. I can still chew, I can still eat, no big deal. Bilateral damage, the mandible might, in a severe case, it's going to be hanging low and open, and the patient may not be able to raise their mandible at all. In a more mild situation, their mandible just might be very weak, and they just might not be able to chew as well. So they may need a puree diet in a more severe case, or just a softer diet in a less severe case. So damage to the trigeminal is going to create an oral stage dysphagia. That dysphagia is going to be difficulty with mastication. Mastication meaning chewing. All right, and now for the cranial nerve that everyone has been waiting for, the vagus. So quick review, you guys will remember that the vagus leaves the medulla and it innervates the velum, the pharynx, and the larynx. And when we say the larynx, we mean the vocal folds, which are muscles, and we mean the muscles of add and abduction, meaning those muscles that bring the vocal folds together, which are important to us in this class because adducting the vocal folds is one of the ways that we protect our swallow, that we protect our airway during the swallow. You guys will remember potentially that, okay, the superior laryngeal nerve, you have a left and a right, and it branches into intrinsic and extrinsic portions. The extrinsic portion innervates the cricothyroid, which is the pitch shifter, the primary changer of pitch. But we're not worried about changing pitch in this class. But we are worried about the intrinsic, the internal branch of the SLN, this little guy, because he is responsible for transmitting afferent or sensory information from the vocal folds back up to your brain. So it's important to feel when something is on your vocal folds so you can cough it up. If you can't feel like a piece of popcorn on your vocal folds or pass through your vocal folds, then you're not going to try to cough it up. So having reduced laryngeal sensation comes from damage to the intrinsic branch of the SLN. When I say SLN, I'm meaning superior laryngeal nerve. And that is not necessarily a dysphagia, but it's a big problem for dysphagia because this is what creates what we call silent aspiration. People aspirate and then don't know it. And if you don't know it, you're going to cough it back up. You're not going to cough it back up. So silent aspiration is and also the person is going to show no overt signs of aspiration, probably, or less overt signs of aspiration if they don't feel it and cough it up, which means people around them are going to be less likely to notice. So silent aspiration is something that as SLPs, we constantly worry about. It's something that we're constantly in fear of, and we're constantly trying to ensure that we're not missing. The recurrent laryngeal nerve, or the RLN portion of the vagus, this innervates all the other muscles, intrinsic muscles of the larynx, besides the cricothyroid. So these are the muscles of add and abduction. And these are the muscles, the cricothyroid, these are the thyroarytenoid muscles, which are the vocal folds themselves. So the RLN is responsible for add and abduction of the vocal folds. Right RLN, responsible for adduction of the right vocal fold. Left RLN, responsible for adduction of the left vocal fold. Okay, so now what is the role of the velum during a normal swallow? Well, it comes into play when that pharyngeal swallow begins and the velum elevates to seal off the nasal cavity. If you have unilateral damage to a pharyngeal plexus, then one side of the velum is not going to be elevating as well. So there's the potential of parts of the bolus getting into the nasal cavity. The vagus also, the pharyngeal plexus also innervates one side of the pharynx. So the right pharyngeal plexus innervates the right pharynx. So if the right pharynx is not squeezing as well during the pharyngeal stage, then there's going to be difficulty moving the bolus through the pharyngeal cavity. So unilateral damage to the pharyngeal plexus, we'll say the right, is going to create a right velar weakness, a right pharyngeal weakness. Flaccid, because it's lower motor neuron, because it's a cranial nerve. How is that going to potentially affect the pharyngeal swallow? Potentially, you're going to have some nasal regurgitation. Potentially, the one side of the pharynx is going to be flaccid and weak, so it's not going to be able to squeeze as tight. And that pharyngeal constriction on that side is going to create slower or problematic movement of the bolus through the pharynx, and you could have potentially a great deal of pharyngeal stasis. If we damage both right and left pharyngeal plexus of the vagus, in this case, the velum is not going to raise and close at all. because the whole thing is flaccid, not just one side. So potential nasal regurgitation. The pharynx is not going to be squeezing very well because both right and left sides are flaccid. So potentially severely impaired movement of the bolus through the pharynx. And if you can't move the bolus through the pharynx, then you can't swallow. Okay. Now let's move to, we've already talked about damage to the unilateral. Well, we've mentioned that damaging the SLN, unilateral or bilateral, creates reduced sensation in the larynx. Reduced sensation in the larynx can translate into a person not feeling aspiration or penetration and therefore not coughing it up. The word would be non-sensate aspiration, non-sensate penetration, meaning that they're aspirating and penetrating but not feeling it. So that would be the problem that would come from damage to the SLN. If we damage the RLN, say the right RLN, then the right vocal fold is not going to adduct during a swallow. During a swallow, if we damage the right recurrent laryngeal nerve, you're going to create a right vocal fold paralysis. And the vocal folds are one of the valves that close during a swallow, during the pharyngeal swallow. So during the pharyngeal swallow, there's going to be less protection of the airway, so there's going to be a potential of an increased risk of aspiration and penetration. With bilateral damage to the RLN, both vocal folds are going to be held open, and you're not going to be able to adduct them little or at all. So you may still have some laryngeal elevation and some epiglottic inversion to protect the airway, but the vocal folds are wide open, and so the person's going to be at greater risk of aspiration and penetration. All right. And once again, if you damage the vagus up close to the medulla, then that's going to impact everything below it. So damaging the right vagus at we'll say the right vagus cranial nerve nuclei, you're going to have a flaccid right side of the velum, so potential nasal regurgitation. You're going to have right side of the pharynx flaccid and weak, potential difficulty with bolus transmission, potential pharyngeal stasis. The right vocal fold is going to be flaccid and not adducting during a swallow, so increased potential for aspiration and penetration. And if you damage right and left vagus cranial nerve nuclei, then you're going to get the most severe version of all this. Nasal regurgitation, because the velum is not sealing off the nasal cavity. The pharyngeal cavity not squeezing, so highly difficult movement of the bolus through the pharyngeal cavity, or no movement of the bolus through the pharyngeal cavity. The airway held open because the vocal folds aren't adducting, creating severe risk of aspiration and penetration. And also that afferent information is not getting up from the larynx back to the brain. So if they do aspirate and penetrate, they're not going to feel it and they're not going to cough.